Artificial intelligence, AI, and machine learning, ML, are hot buzzwords right now and often seem to be used almost interchangeably, leading to some confusion, heightened expectations in some case as to the promise that they bring, and sometimes even apprehension.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals. I'd like to start our session today and thank our listeners who occasionally provide insights and feedback to our program. We're very fortunate to have a broad category of topics and excellent subject matter experts to help educate us. On previous podcasts, we've had briefly covered the high-tech topics of artificial intelligence and machine learning, also known as AI and ML, and this will continue to be a topic of interest going forward. So today, we want to use this edition as an educational opportunity to better understand these high-tech topics and how they can positively impact total quality, cost of care, and ultimately improve patient outcomes. I'm delighted to have with us today in Dallas, Dr. Ashwin Prakash, a data scientist. Ashwin has an impressive educational background with an international medical degree, a PhD in bioinformatics and computational biology, and a postdoctoral research fellowship at Johns Hopkins in biomedical engineering. However, we reserve the bragging rights for the University of Texas at Dallas, where he earned his executive MBA. So welcome to the Business of Healthcare podcast, Ashwin.
Thank you for having me.
Well, most of our audience, they have a very broad view, and if you have a realistic understanding of ML, machine learning, and AI, artificial intelligence, we hear those terms being used more frequently. In addition to machine learning and AI, we hear a lot about analytics. Tell us, how are all these connected and related?
Yeah, I think that's an important question. So artificial intelligence, AI, and machine learning, ML, are hot buzzwords right now and often seem to be used almost interchangeably, leading to some confusion, heightened expectations in some case as to the promise that they bring, and sometimes even apprehension. Artificial intelligence, in layman's terms, is basically an umbrella term that is applied to pursuits of developing computational systems endowed with intellectual processes characteristic of humans, or even better than human abilities. Psychologists usually generally characterize human intelligence by combining certain attributes, such as perception of one's environment, learning from past experiences, reasoning to draw inferences, and problem solving, especially in situations which are unencountered as yet, and also finally using language or some form of communication. And the field of AI essentially focuses chiefly on developing these key components of intelligence into computers. Machine learning, on the other hand, refers to a relatively narrow group of algorithms. They are able to learn from historical data without being explicitly programmed and often use statistical models. They then apply this learning to perform a very specific task, such as, say, predicting likelihood of default on a loan or risk of readmission, etc. In a nutshell, ML learns and predicts usually based on passive historical observations, whereas AI implies an agent which interacts actively with the environment to learn and take a wider range of actions that maximize its success. Data analytics, which is another term that you brought up, is an even broader term and refers to the discipline that helps individuals or organizations make sense of data. Analytics can be broadly classified into descriptive, prescriptive, and predictive. And in many ways, descriptive analytics is nothing but the application of statistical methods to describe patterns within data. Machine learning, in a sense, can be thought of a specialized form of predictive data analytics. So in a sense, all of these terms have some overlap, but they're not quite the same.
You sound like a data scientist for sure, and I think I picked up a few of the key things. You know, when I think of AI, I tend to think of this super smart system that'll either help me do my job or it might even do my entire job for me at some point. And, you know, I hear all the time about these supercomputers that can win at Jeopardy like the IBM Watson. And we experience those hidden AI things, I think. I think this autocorrect when I'm texting and I type in, you know, one word, it comes up with a different one. That might be AI. And every now and then I have to be careful if I say the word Alexa because it might kick off in my studio here. But those little conversations, you know, I kind of think of that as AI. Or is that AI or is that machine learning or is it both? I'm still not clear. Is one start before the other? Does one end up with what the first one does? Kind of go a little bit deeper on that for me, if you would, Ashwin. I think our audience could appreciate that.
Sure. So the ultimate ambition of AI or general AI, at least in our popular imagination, as you said, is to produce a machine whose overall intellectual ability is indistinguishable from that of another human being. This was popularly called as the Turing Test. And this goal generated a great amount of interest in the 1940s and 60s. But such early optimism has sort of given way now to an appreciation of the extreme difficulties that are involved. It seems like we are certainly a long way away from building a system that can match human flexibility over a wide range of domains or tasks, which might seem trivial for an average human. Nonetheless, there's continuing advances in processing speeds, memory capacity, and most importantly, our ability as a society to generate humongous amounts of data, especially digital data, that has accelerated a subfield of AI called applied AI. Applied AI aims to produce commercially viable smart systems that have attained or even surpassed, in some instances, the performance levels of humans in performing certain specific tasks. So to answer your question, are they all AI? Yes, in some narrow sense, applied AI falls within the boundaries of AI. And it has found its way into applications as diverse as medical diagnosis, computer search engines, voice and handwriting recognition, etc.
You know, I was watching a CBS 60 Minutes show last year, and it featured a guy named Kaifu Lee. And Kaifu Lee, he lives in China, and he's funded more than 50 AI startups. I think he has 10 of them that are worth $1 billion, and he has 3 that are worth more than $10 billion. And Kaifu Lee, his focus is truly on facial recognition. That's the key area for him. And he's trying to use this technology to help children learn. In China, a lot of children are being left behind while their families move to the cities. And these left behind students are in these classrooms and they're not getting the appropriate number of attention points from the teacher, apparently. And so he basically makes a point that this is not general intelligence, that these computers, they can read the faces and grade papers, but they really don't know why the children are in the classroom. And he says this whole process, he refers to it as deep learning, and that the computers used to give them rigid instructions, but now the computers are programmed to learn on their own. That sounds pretty intense to me, this deep learning, or is that the same as machine learning? And so he's talking about how to help using facial recognition for students in classrooms. How about giving us an example of how this might be applied in the healthcare area?
Sure. So as you mentioned, traditionally computers used to be given rigid instructions, and that is quite a simple form of learning where you could basically involve providing clear, rigid rules or thresholds to a system that can be implemented as deterministic control statements in a program. Such learning would be called route learning. And for example, let us consider a healthcare example where we have a simple program with hard-coded logic of taking in measured blood pressure values from an automated cuff and comparing it with set thresholds and outputting whether a person at that point or that particular value is hypertensive, hypotensive, or normotensive. We wouldn't consider that particular system as especially intelligent. But there was certainly human intelligence involved in establishing those thresholds in the first place. It was through extensive epidemiological studies, compiling thousands of unique blood pressure measurements in cases and controls, arriving at the right cutoff point in order to define hypertensive and hypotensive. So now, however, the idea behind machine learning is that instead of providing a model or a program with these pre-computed thresholds, we instead input all the raw data for the model to basically infer its own thresholds and cutoffs to classify patients into cases versus controls. The advantage of this method is basically it allows for greater flexibility in the model as it encounters patterns in the data. So essentially, while a traditional model, which was hard-coded, would always give you the same response, in this case, the same model, given data specific to a pediatric age group, will set different thresholds or come up with different thresholds, versus when the model is fed with adult patient data, it comes up with completely different thresholds of blood pressure. So using the same model, you're able to achieve two different things in this approach.
Okay, so let me ask you this. It sounds to me like you need to have a lot of data in order to do machine learning. Is that true?
That is true. So it's true, and also it depends, as the answer to most questions go. So the approach that I just described is called supervised learning, which accounts for almost 80 to 90% of ML models that are trained today. And in this particular approach, what happens is you provide a model with a combination of input and outputs, desired outputs, and the machine basically takes these examples and learns using these examples. In this particular scenario, what happens is, in order to discriminate between case versus control, which is basically your target, you need several examples of the case and several examples of the control in order for the machine to be able to reach a certain level of confidence to be able to discriminate between those two.
Okay. I know that going back to Kaifu Lee, when Scott Pelley was visiting over there in China, he was walking down the street, and they're taking pictures of everyone's face in China all the time. The privacy issue is not the same as the United States. And as he's walking down the street 100 yards away, the system detected his face and came back with the statistics and said, yeah, it looks like you're 6'1", you weigh 173 pounds, and you're 61 years old. And Scott Pelley said, that's pretty impressive, but I won't be 61 for a few more days. How do you get that accurate? And Kaifu Lee says, we have billions, literally billions of faces that we've scanned. And with that, the accuracy of our machine learning becomes really, really good. I would think that in the healthcare world, you don't get billions of things to be at a smaller subset, but the more data you get, you probably get better models. Is that true?
Yeah, that's absolutely true. So if you think about the way learning itself in the name machine learning works, it basically works so the problem itself is sort of rephrased and formulated as a problem of optimization. And in this case, what we're trying to optimize is basically minimization of a cost function or a loss function. And without getting too much into the weeds, essentially what a cost function is basically the amount of misclassification or the errors that were created between the predictions of the model versus the actual ground truth. And that is quantified for any given data set, a training data set. And then the objective is to basically tweak the assumptions and the parameters of the model in order to get better at that particular task. And the advantage that having billions of data points gives is basically you're able to iterate through this process again and again, getting slightly better and getting accuracy levels which are either acceptable or 100% if the task is much more simpler. And so that's the benefit that you get from iteratively learning. And this is sort of significantly different from the way humans learn, if you think about it, in that for a human person or even a baby, you show them one photograph of a zebra and they can pick out a zebra from anywhere among 1,000 other animals in the wild. For a machine learning model to get that level of accuracy, you need to give them hundreds and thousands of models of not just the zebra, which is the case, but also of all the other organisms or animals that you don't want to call a zebra. So that, in a sense, sort of underscores how data hungry these models are.
Very good. Well, I want to talk a little bit more detail about what you do at your job in a minute. But before we go there, I know you're the chief data scientist at a company called Post Acute Analytics, and we'll touch base on some of the activities that you developed there. But, I was listening to a book on Audible, and it's an interesting book. I think our readers would like to hear it too. And it's called Deep Medicine, and it's by Eric Topol. Topol, Eric Topol. And he purports that the barrier to entry is quite low. He gave an example of a 15-year-old student who got a hold of an algorithm from Microsoft and then went and got a tremendous amount of public or research data related to the eye. And they could sit there and came up with a method of detecting, eye disease, and they turn it into a company. So they're like 17 years old and they're on their way to becoming multimillionaires, because they got into this deep learning, machine learning thing. Your education background is incredible, but when did it become obvious to you that you were in the right field and that this was the right thing to start spending your energy into? And after I hear that story, we'll jump into what you're doing there at Post Acute Analytics. But what was your aha moment?
Sure. For me, the aha moment was basically as I was training as a physician, I noticed that most of our beliefs and the way we practice medicine comes from our unique way of how we've been trained or which school we went to, and also from the journals and other articles that we read. But I feel like at that point, I felt like one of the limitations of this approach is that you can only read that much and you can only keep up to date by that much. And it takes a significant level of research and evidence for articles to eventually show up in the popular clinical literature. But what machine learning and AI, and especially the huge growth of data in healthcare, can help us do is basically speed up that process of discovery almost in real time. And this became a lot more apparent, especially during COVID last year. And of course, it is still ongoing, but nonetheless, what we found was that we were dealing with a completely new disease process where we couldn't have the luxury of going to clinical literature in order to determine what we want to do. And so in such instances, going back to our own data, our own patients within the health system was a huge plus for us in determining the course of action and how we need to manage these patients.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
So you're the chief data scientist at Post Acute Analytics, and I'd like for you to share with us what Post Acute Analytics does. I know it's related to the tracking of patients across the continuum of care, but that's a high level statement. But we'd like to know what you do there and how you use this machine learning AI to really improve the process of taking care of patients. So why don't you tell us the story of what's going on there and how this applies?
The amount of data points that healthcare systems are now collecting for each patient during their stay has enormously increased over the last decade. But there's this huge void in data visibility and on the patient once they leave the facilities and move into a post-acute care setting or go home. At Post Acute Analytics, what we try to do is basically bridge that gap in the care continuum and fill that void by integrating and bringing visibility into the data, even for patients after discharge.
Let me ask you this, just to make sure our audience understands what acute care is and post-acute care. Why don't you give us a typical example of a situation where people are going through some type of treatment, at one point getting care from certain folks, and then they move along the line. Kind of go a little bit deeper on that so we can see where this improvement might take place.
Right. So typically the way our healthcare systems work is when a patient is sick enough that they require a hospitalization in an acute care setting. These acute care settings are your regular hospitals that you see around, which are able to care for a patient at that high level of care, say ICU level of care, or are able to provide inpatient services for surgical patients and surgical procedures, which are complex enough that they require a stay in the hospital for extended periods of time. However, what happens is that once the patient's procedure or the level of acuity of the patient reaches a stage where the patient can be managed safely without needing too many procedures or interventions by another facility which is able to manage the normal rehabilitation or the improvement of the condition of the patient over time. What we do is basically transfer this patient from an acute care setting to a post-acute care setting, which involves the recuperation of the patient over time.
So that would be a rehab center or a skilled nursing facility, something like that?
Correct. So depending on the patient's spectrum of acuity, the really high acuity patients who require a lot of care go into these rehab facilities, or the patients with a slightly lower acuity go into skilled nursing facilities. And then in the end, the patients who are doing quite well, that they can manage themselves without continuous monitoring, can go into home health sort of situations.
Well, that makes sense. So there's a continuum of care here. I try to look back on situations I've experienced, with family members, et cetera. How do you know when you leave acute care and go to post-acute care? I think the doctor probably decides that. There's some decisioning that takes place. Then how long do you stay in a rehab or skilled nursing facility? And what do you do when you get home? I mean, these decisions seem like you could maybe make some bad decisions or maybe make some better decisions. Is that where the machine learning comes in?
Yeah, so those are some really good points. So oftentimes, case management and care utilization teams at these facilities lack both the bandwidth and tools to closely monitor the plan of care for every patient in the facility. And what happens is, this is where post-acute analytics comes in, where what we do is provide the benefit of machine learning as well as data, which we integrate in real time in order to help course correct during the course of treatment, in order to better plan for discharge and better plan for a setting that the patient is most suitable to go to, tied in with the outcomes. And one of the key differentiators, we believe, is a class of algorithms that we use in addition to risk stratification and risk prediction algorithms, are something called recommender engines. And recommender engines are essentially models which are similar to the way Netflix works and recommends movies based on your individual viewing history, as well as history of what movies were liked by others who are very similar to you. In this case, what happens is, depending on the specific condition of the patient and the specific comorbidities, a plan for discharge or suitability to a certain post-acute setting is sort of set. And so the real-time data which comes in post that helps us define or refine that particular plan over time and help manage those patients in order to improve those outcomes.
Okay, so here I am in the healthcare area. I'm trying to be the instigator here a little bit and challenge this a little bit. So here I am working as a healthcare professional, and I'm used to doing things according to the procedures and logic that's set forth I'm going to keep this person in the skilled nursing facility. I'm going to work with the patient's family to communicate with them. And when we decide to do this or decide to do that, I feel good about my decisions. Now, if you come along with your company and you say, look, we've got a better way of doing this. We have a way to improve the efficiency, cut the cost, have better outcomes. And I want you to, trust me to use my advice that's coming from this machine learning environment. I want to trust you to that. How do you get buy-in and acceptance from me and other healthcare systems and doctors and the support clinicians to say, yeah, that makes sense. Let's use your methods. Did you get a lot of pushback on something like that, Ashwin?
There's definitely pushback, and there are definitely barriers to get adoption. And this sort of falls in with the diffusion of innovation theory, where some facilities, some providers will rush out and adopt these new technologies first, and also will actively invest in developing these technologies, hoping that this is going to be a competitive advantage and a point of differentiation, while there's always going to be others who will wait until the technology is mature enough and pervasive enough before they themselves adopt it. So having said that, there are definitely some key barriers, like I mentioned. So one of those is figuring out how these predictive models can be operationalized in the clinical workflows and the pathways at the bedside. Addressing alert fatigue, because despite the fact that interoperability between systems in the healthcare has definitely increased, there are still significant gaps in the systems and databases, making addressing each of these alerts almost a chore and a distraction from practicing medicine. So we need to definitely work on improving our specificity of our models. Improving explainability of the models is another big pushback, because many of these machine learning models, especially deep learning that you mentioned before, tend to be black boxes which take in and ingest inputs and then provide an output with no explanation as to why that particular output was predicted. And I think most importantly, it is to identify clearly what use cases will benefit most from the use of this technology, and being completely transparent about the strengths and the shortcomings of these models in order to build trust among the clinical providers. Because in many cases, what I've seen is physicians see these models as a threat, and the pushback is mainly in the fact that their performance is being benchmarked against these algorithms. And their argument is essentially that patient care is not completely reducible to a bunch of clinical or quantifiable facts, and there is still some amount of subjectivity involved in patient care. And so the optimum model, in order to get buy-in, in my experience, is communicating that the machine is taking you 60 to 70% of the way, but the clinical judgment still has to happen, and the physicians can focus in bringing their clinical judgments on those higher value tasks. And so in a sense, this will allow for better utilization of their time, of resources, better outcomes, and ability to scale and hopefully lower costs in the long run.
Yeah, I think that fits in very nicely with the movement towards quality. We teach quality improvement here at the university for our physician leaders and our clinical leaders. And the main thing right now is to, have what you call continuous quality improvement, CQI, and lean. And both those are tools that help improve the process. And, causes for change, and it causes for improvement. And with that, usually, the value increases because the cost is going to go down. And so the cost of care and ultimately the patient outcome is better as well. So I think that fits very nicely as you package it to be part of a quality movement, that you get a lot more acceptance from that perspective than just saying, hey, this computer is going to do something better. I think we've seen this in a variety of other areas too, Ashwin. Radiology, where, the machine learning can read a scan and sometimes find things that an experienced radiologist wouldn't find. And, the machine learning doesn't suffer from fatigue. This is my 28th scan to look at today, where I'm tired and I want to get home and help the kids out with their homework, and I miss something. Machine learning doesn't have that problem either as well. So there's a lot of things going on there. This is a really interesting topic that we've been able to discuss with you. Where do we think this is all going in the future? Obviously, there's a lot to happen. Going back to this Kaifu Lee, he said that, hey, AI is going to make a bigger impact and throughout all of history, even more than electricity, that, it's going to change the way that we live and we exist. And that sounds scary on one hand, because a lot of people, they don't understand what it can do or how it works. And a lot of people are fearful that it'll be abused, et cetera. But I think when it comes to healthcare and the things that you're doing, you're actually finding ways to improve processes and help people with their outcomes. So in closing thoughts here, where do you think this goes in your line of business? How good does it get, Ashwin?
Certainly, there are several areas in healthcare where there's tremendous room for machine learning to contribute. But I think one of the key areas that consistently comes up is moving beyond using clinical variables to utilizing external data, such as social determinants of health. There's, I think, ample evidence now that adverse healthcare outcomes are closely related to socioeconomic and psychosocial factors. But our current model of care delivery falls short in taking these factors into account while planning care and delivering care, both in acute care settings, post-acute, as well as in home. The other area that really excites me is the area of opportunity in IoT and integrating data that's coming from various sources, including wearables, to enable the collection of health data in a more pervasive manner. As we know, a majority of care for chronic conditions usually happens at home, and the key person with the responsibility for that care is the patient themselves. And what integrating wearable data and other data basically gives us is that ability to provide the tools that are necessary for the patients to manage their disease condition, in addition to using or leveraging other technologies like telehealth in order to sort of better manage their care, so that we actually have scalability in the whole system, and hopefully, as I said before, reduce costs in the process.
Well, we know that the next generation of doctors are going to be adopting this technology going forward as part of their education process, just like you've experienced. And we know that these type of approaches will change the way that we manage through and we lead through the healthcare world that we live in. So it's been a great pleasure to have you on the Business of Healthcare podcast. We look forward to seeing more and more on these podcasts related to AI, and hopefully this will help people understand and get a better feeling for what this is all about. So thank you again, Ashwin, for joining us today.
Thank you. Thanks for having me again.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jindal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.